So much, Mr. Zanga, and good morning to you once again, and good morning to those who are just joining us. So without wasting much time, I'll proceed with my presentation, which is on basic fetal examination, heart examination. But I'm just glad that my colleague who presented fetal anatomy has already done a lot of work for me. So I think I'll be giving you some challenges in this presentation. I will jump most of the issues that have already been discussed by my colleague. The reason why I thought I should share with you this topic is because of the issues which I've listed there. I forget the first one, but the second one, where I'm saying there's lack of standard approach to fetal heart examination. Forget the first trimester is done. So there's lack of fetal heart standard in fetal heart examination, so that most babies who come to us, we end up, we're a referral center for fetal defects. So whenever we see these babies, we pick up fetal heart defects that have not been picked by the screening team. People will have referred patients to us from various centers. The skill inadequacy is clear that in our region, there's a lot of skill inadequacy in terms of fetal heart examination. So this is why I thought it is important for me to share with you this topic. To just show you our cohort of 9,513 pregnancies that we have scanned in our unit, it's a certain time. We've not scanned more than this. So these are the conditions that we picked up here. So you can see that cardiac defects are now the most commonest defects. When we presented I think 2 years ago, cardiac defects were not very common in our series of cases, because probably people were not aware, or we believe that the scanning is slightly improved than it was before, and we are seeing more and more cardiac conditions. And forget the pulmonary hyperplasia, but this is the distribution of the condition that we have come across. Out of the 92 we had there, these are the defects. I think they just mirror what is in the international literature in terms of having the VSDs being the commonest cardiac defect. And you also have this distribution, as you can see, of various conditions. So cardiac conditions do exist, but it is the detection that we have to improve through a standardized way approach to scanning. My colleague explained well how to get the images, so I'll jump this and I'll go straight to the talk on the fetal heart rhythm. Just checking the fetal heart on its own has to be done properly. How should we be doing it so that we can pick rhythm abnormalities? Ideally, we should be putting our probe within the ventricle. Either we can put it within just below the tricuspid valve or below the mitral valve with a gate of 2 millimeters. Then we should assess the rhythm so that we can pick where we place the gate should be very close to the IVS, the interventricular septum, so that we can pick both the inflow and the outflow. As you can see that these two waveforms there represent the arterial systole, and this waveform represents ventricular systole. This will allow us to determine the rhythm of the heartbeat as a first step. Sometimes slow hearts or hearts which are not beating normally are easy to see. You can see from this video here that certainly there's no regularity to this heartbeat, as you can see clearly. But of course, you have to confirm this by putting a pulse wave gate exactly where we said you should put it. In this case, you should put it very close to the interventricular septum, just below the AV valves, so that you can pick both the inflow and the outflow tract. Of course, as part of fetal echo, we should also make sure that the E and the A wave, they have the right velocities. As you are aware that the passive filling of the atrium has a lower velocity than the active filling of the atrium in uterus. So you can see here by the E and the A wave, this is the normal E and the A wave pattern. which you should expect. If there is a reversal of this pattern, then probably you are looking at some obstruction somewhere, and these babies will need a thorough evaluation. So this is what is important about doing the fetal heart. Just basic fetal heart can give you a lot of information of what's going on with rhythm issues. In trying to do fetal heart, sometimes you can clearly see that there are some skipped beats due to some ectopics that do block the transmission of the normal beats. So this is an example of an ectopic beat that is obstructing the passage of a normal beat, and we can see here that the pattern is interrupted at this point here. I think the most important image is that having an ectopic, it is important to verify that the heart rate is within normal. Like in this case, you can see this fetus at a heart rate of 123. Certainly with a 123, this should not affect the fetus in uterus, but there is need to follow up this fetus to make sure that this doesn't deteriorate into something else. But 123 beats shouldn't harm the fetus, even the presence of an ectopic. It will be checked again after birth. Sometimes you could have a complete heart block, whereby the atrium and the ventricles, they are beating asynchronous. There is no direct connection, as you can see there, that each is beating at its own beat, more or less. But in this case, it's more like, in certain parts, there's no connection. So this was a very slow heartbeat of around 50, 60 due to a complete heart block. So this is some of the information you can get just from checking the fetal heart rate in the right way. The situs abnormalities, my colleague has already explained to you what situs is, that you should always know how the baby is lying, so that you check if the stomach is indeed on the left side in terms of how the baby is lying. First of all, you establish how is the baby lying in the mother's womb, so that you know which one is the left and the right. Then confirm that the stomach is indeed on the left, and also confirm the vessels. Make sure that the aorta and the inferior vena cava at the level of the abdomen, they are in their respective position, with the aorta more towards the baby's left of the spine here, and the inferior vena cava more to the front and to the right. Of course, then we confirm also that the apex of the heart is looking in the same direction as the, so then we should confirm that the apex of the heart is looking the same way here. Right. Then these are the situs, some of the abnormalities you can get when you are trying to get a situs. Let's see what this video gives us. So we can see here that there are two vessels close to each other. That is the aorta and another vessel, and we don't see the inferior vena cava. This is a case of interaction of the inferior vena cava with azygous continuation. So we can see here that it is very important to check these vessels, because sometimes you could get a stomach at the right place and the heart looking like in the right place. You could think things are okay, but this was a case of a heterotaxy with left isomerism. Then we can also see here, we're trying to see how things are arranged, but here this is a case of a congenital diaphragmatic hernia with the heart squashed to the left. You can see the filling of the ventricles there and the stomach within the thorax. The four-chamber view, my colleague has explained everything on the four-chamber view. It is important to get the four-chamber view in the right way, because more than close to 80% of the defects of the heart will be suspected by looking at the four-chamber view in the right way. It is already covered, but I'm going to show you some cases, some interesting cases of the four-chamber view. Right, so this is the filling. Probably my colleague didn't do the color, but let me show you the filling. That you should always check that there is equal filling, and that the filling is going all the way to the apex of the left ventricle, to just make sure that the left ventricle is apex forming. Very important. And of course, on this baby, you can see that there was probably a very tiny interventricular septum, probably close to the muscular portion there, that aliasing part. So that's the 4-chamber view. It allows us to see if the AV valves are opening nicely, allowing blood to flow inside with these colors we see there. Very important. And also, it allows us to confirm that indeed there's good symmetry in terms of the feeling of the heart. Right. So then this is an image of, let me see here if I can play this image. Right. There we are. 4-chamber view, trying to get the 4-chamber view. You can clearly see that there's no 4-chamber view here. There's probably a large AVST there. And it's a very complex cardiac condition we are looking at. We are seeing a lot of chambers around the heart. So this is a grossly malformed heart. We are trying to get a 4-chamber. You can see there's even a pleural effusion here, pleural fluid in the pleural space here. So that's an abnormal 4-chamber view. This is the same heart, trying to look at the same heart. You can see even the feeling. There is no symmetrical feeling in this heart as we put on the color there. And there appears to be a very large ventricular septal defect communicating feeling the other side of the ventricle there. And I'll come to the right. Then we do have this one. Again, we are trying to get a 4-chamber view. If you look at this heart carefully, you can see that you are not getting the normal heart. Even if you try to do the angle that Mr. Chigayo mentioned, you will see that probably this is more than 70, whereas the angle should be between 30 and 70 degrees for a normal heart angle. And you can see that there is a clear gap here, the AV, atrioventricular septal defect. Very, very clear here. And the beating is not normal. Again, you can see that this is not normal way the heart should be beating. And at the level of the, if you look at the level of the aorta, I think probably Mr. Guy didn't mention this, but we're supposed to just see the ascending aorta here. But at this level, you can see that there are 2 vessels instead of 1. So that's an abnormal heart, grossly abnormal, an AVSD here. And I think it should be the same case which I showed you where the continuous of the zygous vein with the interruption of the inferior vena cava. Right, then I'll move on to the next one. Just to show you the pericardial effusion, slight pericardial effusion of less than 10 millimeters. Normally it's a normal variant. All you have to, if the heart structure is normal. Let's play this video. This is a case of asymmetric ventricles. I showed you very normal ventricles, but when you look at these ones, you can see that there's clear asymmetry here. The left ventricle looks smaller. This was our case of suspected aorta. As you are aware that aorta, coarctation of the aorta is a very high false positive in utero. These babies need to be followed up, not just immediately postnatally, but for a long time. Whenever you suspect that there is coarctation of the aorta, there we go. Then again, you'll be trying to do a 4-chamber view, and you see this kind of a heart. Look at that. You can see the thickening at the septal leaflet of the tricuspid valve. They're very thickened septal leaflet. The same heart, trying to get the feeling. We can see that there's a very large regurgitant jet. We are seeing the regurgitation. On this case, we labeled this Epstein anomaly because of the low insertion we have of the septal leaflet of the tricuspid valve here. So this was a case of Epstein anomaly. You can see that the heart is very enlarged, cardiomegaly, feeding the rest of the almost the whole chest there. Yeah, this baby is a poor outcome, really. Then let me go to the next one. This was probably a 16-week baby. So I'm sorry, the machinery we use here was not of good quality, but we can see on B-mode scanning that we do not, the heart didn't look that symmetrical here, and look too pushed to the front, but it was not symmetrical. You can see there's one main ventricle here, and the what is supposed to be the left ventricle, it doesn't seem to be well formed, and the apex seems to be formed by the right ventricle. So when we play that, that's the color now, we can see that there is an asymmetry in the filling. Look at that, asymmetry. And there's very little filling happening on the left side. And this filling seems to be coming from the VSD here. This case, we suspected hypoplastic left heart. We just picked it up early, but we thought this baby had hypoplastic left heart, and we followed up. I think we ended up confirming this condition. All right, to just demonstrate how to assess the interventricular septum, you can see here the interventricular septum, we see the pulmonary veins draining into the right atrium as well in the same image. Right, these are just still images. The two, the still images just show you the very large ventricular septal defect here, and another ventricular septal defect you can obtain by just looking at the 4-chamber view properly. Right, another AVSD, you can see how the valves open here, that there is a huge gap. This is the same baby. You can see with the colors how they are. There's a common entry into the two ventricles, and the color divides there in a case of an AVSD. Outflow tract abnormalities, my colleague has already taken you through this. I just want to show you the defects, some of the interesting defects that you should always be aware of. You can see here nicely the outflow tract, the aortic valves beating. This is the color to just show you that there should be a laminar flow there, very little aliasing. Probably we didn't set our scale well here to remove this aliasing, you see. But that's blood going across the aortic valve smoothly without any aliasing. And of course, that's the measurement. Let's see the right outflow tract, already mentioned, but again, you see the pulmonary valve should always be seen and measured, and also the velocity measured in the case of a detailed fetal echo. Right, there we are. That's the flow again at the level of the pulmonary valves. All right, let's see 3-vessel view. Yeah, 3-vessel view there. And this 3-vessel trachea view, you can see the V sign coming out nicely. The measurements, let me go to, yeah. So this was a case of, if we look at the 2D image, you can see that we're not getting the typical 3-vessel view, but we have the trachea here, and we do have what looks like the aortic arch coming on the right side instead of the usual left side. So this was a case of a right aortic arch. Of course, we suspect that there could have been a double aortic, because there is something that may look like a ring when you look carefully. But this was a case of a right aortic arch. If there are no other defects, the outcome is normally good. Just a 3-vessel view. Let's see if we can get other. This was a case of where we suspected overriding aorta. As you can see, the draining of the vessels into the main vessel, the aortic vessel. This case, we are trying to get 3-vessel trachea view, but you can see there is one main vessel. The others are very, very narrow. When you put on the color, we noted that one of the vessels was flowing backwards, as you can see there. So this case, we suspected severe coarctation of the aorta. On this case, that was our working diagnosis.